project, I may say so. Now, although the topic was neuromuscular hip disorders, I've tended to concentrate on cerebral palsy, which is the commonest neuromuscular problem. Although we have others like Duchenne muscular dystrophy, we have polio, we have hereditary sensory motor neuropathies. But commonly, what we may see is cerebral palsy. That first slide, of course, tells you the children we commonly see, how they walk, the energy expenditure, and that's Dr. Mulerwa trying to help one of them. Cerebral palsy, I think, though not well documented in Kenya, is a common problem because of poor maternal-child health care. Now, definition of cerebral palsy is an unprogressive brain lesion or pathology. However, the musculoskeletal problems, that's the bone muscles pathology progresses, and that's why they tend to get bedridden, more so if they put a lot of weight. What is noted, the bones grow faster than the muscles. And of course, the muscles, as they grow, they gain the length as well as the cross-sectional area, and that tends to explain the dislocation of the hip. The muscle tendon units, of course, they get contracted, thus leading to joint deformities as well as instabilities. The bone torsions, we see them in the tibia as well as the femur. The biomechanics of the joints that are affected, particularly the hip, the knee, changes drastically. And that, of course, raises the energy expenditure as well as affecting the gait. Cerebral palsy classification based on physiology can probably divide it simply into spastic and unspastic for the purpose of this discussion. Then the hip, of course, basic sciences are important. In cerebral palsy, the hip is normal at birth, but slowly it gets dysplastic because of poor abduction and non-weight bearing. However, this can be prevented in various ways, which includes, of course, braces and pillows in between the thighs, as well as symbols of tissue injury. If we, like I do in thorough hip surveillance, is critical, and we pick hip dislocation at a very early stage. And this is based on the GMF CS subtype. The type 5, they tend to have more hip dislocation problems than the type 1. And also the rate at which this migration occurs is based on the same. The growth and development of the hip, of course, we look at the acetabulum index, the neck shaft angle, the version of the neck of the femur, as well as the acetabular morphology. When you're at that, of course, the weight bearing, as well as the normal bone development, particularly acetabular development, depends on the tridentine cartilage, the secondary apophysis, as well as appositional growth, periosteo bone laying down. Early appropriate picking of this one, of course, will prevent the hip dislocation. What hip pathologies do we expect? First, we must appreciate that this commonly occurs between 1 and 8 years of age. So we shouldn't concentrate on these ones. But the highest peak is between 2 and 6 years, second year of life being the commonest. Why second year of life? This is the time, of course, the muscles, the brain is growing very fast. And because of that brain growth and muscle growth, then the hip pathology sets in because of the imbalance of these muscles. Adductors and flexors have different power compared to their antagonist. The center of rotation as the hip tends to migrate laterally and superiorly changes from the center of the acetabula to the lesser trochanter. So it's like the femur is being suspended. That, of course, leads to the poor development of the acetabula, which becomes shallow and more vertical as well as the version of the acetabulum changes. That's why we may have posterior superior hyperplasia, anterolateral hyperplasia. And when we are planning the surgery, I think those are the things we have to think about. The proximal femur parameters. In these children, of course, generally in children, the neck shaft angle changes from 140 degrees to almost 132 degrees in adults. In adolescent, in adults comes around 120, 125, depending on the sex. There is also. In cerebral palsy, the neck shaft angle vagal state remains, or it remains more open than in normal children. Acetabulum index is also normal up to 30 months of age. So if we pick those children before 30 months of age, which is roughly 2 years, then we can be able to prevent these acetabulum malformations. The femoral version also changes from 140 to 126 at 4 years, adolescent about 19, and adults 8 to 15 degrees. The diagram below there trying to denote, to define how the version of the neck is measured using digital cameras. What is the clinical importance of this? One, in hip, this cerebral palsy hip dysplasia, the patients lose abduction and affect joint reaction forces. And that, of course, will affect the degeneration rate. Imposes inefficient energy expenditure at rest as well as mobility. If you remember the second slide, those children are spending a lot of energy in their movement and hence affects the growth in general. They also develop contractures, which leads to crouch and scissor gaits. And reduced joints, of course, will progress to osteoarthritis. Non-ambulatory children have difficulty in transfer on their mobility aids, that's the wheelchairs, as well as perineal care is a problem, and pain. Many a times patients, mothers bring their children because of poor abduction and hence poor perineal care, as well as pain. Pelvic complicated because of the imbalanced muscles. This, of course, will lead to scoliosis also worsening. These children also tend to get pressure sores on their trunk or on their hips because of the position. The risk factors of dislocations include, of course, in GF gross motor function classification 1, the migration percentage increases by 1% per year. So if you are tracking these children with a well-taken X-ray, that's what you may expect. However, in children who have a higher gross motor function classification system, 4 and 5, this tends to increase by 10%. And when you note that, that will suggest a likelihood of dislocation and early intervention is necessary. So in general, dislocation or migration percentage correlates very well with age. As the child grows, the migration percentage increases, and it's because the muscles are getting strong and the brain is also becoming more active. The risk is highest at 2 to 3 years of age, like I've alluded earlier. When you see a head shaft angle, the increased head shaft angle, of course, increases the risk by 1.6%, because if the neck is more invagus, then it's likely to dislocate. Lack of hip surveillance should also be taken as a risk factor, because if you take it, if you pick this pathology array, you'll be able to prevent hip dislocation. Surveillance, we don't have protocol for our surveillance in our country. One thing I've appreciated is the cost of their coming to see a doctor, the transport inconveniences in our matatu. This discourages them from getting medical attention. More so the old children, adolescent age group. In a matatu, gross motor function type 5, parents are very uneasy. The surveillance, of course, is mainly based on the clinical. So clinical examination is very key, and X-rays must be well taken, as we shall see later. The screening should start at 2 years. Why 2 years? As we have said, the hip is normal at birth towards the 2 years, 3 years, and that corresponds to the brain and muscle growth. Then, of course, if there are flexion, extension, the tightness in or reduced motions in flexion, extension, rotation, which is internal and external rotation, that may, of course, affect the hip normal anatomy relationship. Labeling the discrepancies is a common observation. In the European countries, particularly Europe, they tend to use the Australian surveillance program. US use their own. So we ought to develop our own program of surveying these children. I start them, immediately I see them on contact, I start following them at a certain scheduled time. Many come, others fail because of the puberty. That's how the Australian protocol is programmed. You can see towards the type 5, the frequency of seeing them is higher than the type 1 and 2. Physical examination, what do you go for? Evaluation, particularly for the candidates who are sitting. Passive range of movements of the hip, the knee, and the back is very key. Value and apparent limb length, dynamic contractures based on Tardy scale, and also modified outward scale. I think it's a good instrument to communicate with. The functional mobility also, you have to look at it, whether they are independent or they are using mobility aids. Assessment of the pain above the hip is very key as one of the common presentation. Muscle tone and gait assessment. There are various tests which we should appreciate in assessing these patients. First is to assess the gastrocnemius sensorius using the Silverstone test. The Duncan-Erie test assesses the rectus femoris. Note most of these muscles are biarticular. Biarticular means they are close in two joints, so they can affect the adjacent joints. The Thomas test for iliopsoas, for Pictorial angle, that is R1 and R2, is very key in planning of your surgery. The posture and the balance is very key. Equilibrium is you try to tip them when you are standing or sitting to see whether they can balance themselves. There are various gait assessment, Edinburgh Visual Gait Score and Observational Gait Score. The best, of course, which we don't have, is computer assistant and DMG gait assistant as assessment. The computer-based, I've witnessed it in one of the hospitals in India where I frequently visit. Physical examination, as usual, through the looking posture. If you look at that photo of that child on a wheelchair, the hips are, the knees are flexed, the hips are also flexed and has a very poor sitting position. That, of course, tells us the vertebral column is also in scoliosis. Pictorial presentation of the test, we have alluded to Thomas abduction test. The first picture is to assess the fixed flexion deformity of the hip, and the second one is showing the abduction. And the knees have to be flexed of the table. The X-ray, you can see the subluxation of the left side, the obliquity of that pelvis. That, of course, try to describe how the skeletal state is. Apart from looking at the child, the other things we look at is the rotation of the profile of the hip, the version, to measure the version. The first picture is trying to describe how the version is measured. Then the foot thigh profile is also very key, because tibial torsion could be one of the differentials in cesarean gait, but also the femur you can get torsion. The foot bisector and also foot plangration angle is very key to complete the physical examination of these patients. After completing your physical examination, the next thing you ask yourself is, you think of is the X-rays. And the X-rays, of course, have to have modified positions. So you have to be in touch with the radiology technician, so that he can project the X-ray or center the pelvis of the patient very well. Now, if the patient has fracture deformity, you have to lift the lid. If the pelvic obliquity, you have to collect that, because that will affect your migration percentage measurement. Now, the second cartoon, the down cartoon, of course, is describing the Parkins lines and Hilgeneliner line, which helps us assess the migration index. The migration, although the Parkins lines is based on the lateral wall of the acetabula, but if there is deformity, then you tend to look at the social line deformity. The social type 2 deformity, we tend to move the Parkins lines to that level. What is this migration? It is the ossified epiphysis that is migrating laterally, and that's what we see. But at the same time, with that X-ray, you'll be able to assess the neck shaft angle, which we said is changing from a higher to the lower neck shaft angle. And that helps in preventing the dislocation. CT scan, the X-ray or the image on your right upper corner is a CT scan, which is trying to objectively assess the version of the neck. But also CT scan is important in surgery, decision of the surgery, and trying to define which rim or the quadrant of the acetabula is hypoplastic, so that you can tailor your osteotomy to that. EOS system of X-rays is becoming very handy in assessing children because of reduced radiation. The benefit of this EOS system is it can take an AP and lateral X-rays at the same time concurrently. Interpretation of this, particularly the layman's migration percentage, less than 10% exposure is normal. 30 to 33%, you can call it displaced, and 90 to 100% can be termed as dislocated. So as colleagues, when you're communicating, normal would mean those percentages. Note those less than 40% migration, most don't progress, but those over 40% of the Layman's index migration progress, and hence an eye on them. The chance of migration is predicted also by the gross motor function classification system subtype. Type 1, there is low or negligible migration. Type 2, about 11 or 20% chance of migration. Type 3, 40%, type 4, 70%, and type 5, of course, 90%. Hence, type 4 and 5, we need to keep an eye on. The winter gauge Hicks types of impringe, of course, type 4 progresses into dislocation. After you have done your imaging, then you sit down, you sit back and analyze the problems the child may be having. The first and most important is the contractures, which may be dynamic or static. Now, to distinguish this one, there are various techniques you may employ. For example, injecting botulinum or Botox. That helps relax the muscles, and any laminant deficit of the joint movement will mean a static contracture. Dysplastic acetabula is another problem because of the poor articulation, the femur acetabula articulation. The femoral hand, of course, becomes spherical, one because it's not molded by the acetabula. The neck is in valgus position, and then increased diversion, pelvic obliquity, and scoliosis. The other problems they have is the pain, sitting balance, and perinochias. So when you have that problem list, then you'll be able to handle or take care of these children as well as their guardians, stroke parents, emotional problems. Goals of treatment after your problem list is one, you need to provide a stable platform. That's a stable articulation between the femur and the tibia. The second goal is you lower the danger of osteoarthritis. If the joint is out of the acetabula is likely to deteriorate into osteoarthritis. For non-ambulatory children, the goal is abduction, achieve as much abduction for the hygiene. And then you prevent pelvic obliquity that worsens the scoliosis. The subluxed hip of the children, of course, will lead to pain in most of the older ones, and also the ease of transfer while to their wheelchair or one standing is another goal we look at. So all in all, I think we are trying to have a patient who can either stand or sit in a balanced state to reduce the energy expenditure. Remember, if the patient is in there is obliquity of the pelvis as well as the scoliosis, this will affect the pressures in the abdomen. And the reflux, my observation is that most of these children tend to have reflux. The other thing, of course, if there is scoliosis and obliquity, is the lung development as and also respiration. Apart from the pressure sores these children may have on their trunks because of their sitting position, and also when you fit them with braces, you tend to have some pressure points. Technical tips. Accurate evaluation is very key, and this starts from the history, physical examination, the imaging, and then you lay down your protocol. The surgical approach, of course, has to be detailed. You have to decide which surgical approach, and you have to have a detailed technical steps which you use to manage this patient. Because you can either go for the femur, go for the acetabula, you can also go for capsulolaphy, opening the capsule. That's why the technical steps are necessary. The scoliosis and pelvic obliquity, as well as fixed flexion deformities, affect the accuracy of the evaluation. That's why we are trying to collect that while taking the X-rays. The importance is the implant of choice, of course, is based on the age of the child. A 1 or 3, 4-year-old child, you may not use the same implant as an adolescent child. The weight of the child is also important, particularly I always want the mothers not to give children a lot of food, because even those who are ambulatory, they tend to be troglodytes, hence the weight observation is very key. Being non-immobile, being under the sun most of the time, and not using their bones makes their bones less dense, or bone density is low. And hence some implants may pull out or fall off. The splintage may also be important when you do some surgeries on them. Surgeon's experience is also very key when you are treating these children. The operation can either be non-operative as well as to prevent most of these problems. The non-operative will include physical therapy. Now the big question is, does stretching help? Yes or no? Do the flames help? Yes or no? In one of the home I usually visit, I've appreciated the role of one, the physical therapy, their stand, their upright posture, flames, which we employ. And hence I tend to incline towards the physical therapy a lot. The efficacy, though equivalent, may not prevent hip dislocation because you may not alter a lot the imbalance of the muscles. And remember why probably there is this controversy is because children's, you may not be able to, of course, appreciate the difference between different age groups, sex, and also the disease process. So may not have a standardized way of assessing them. Blaze plus botulinum, of course, will help. After a botulinum toxin injection, you tend to help to allow the antagonistic muscle to work, and that may delay soft tissue release and also delay or reduce the chance of dislocation. Postural exercises we practice a lot in Toro, where I usually go. Benefits of Botox, despite the only problem with this management is one, the technicality of injecting, the cost and the side effects. In our country, the company starts selling at least an ample of 100 international units, about 25,000. Many parents may not afford that. But it decreases the spasticity, of course. It helps in stretching, improves the range of movement, and improves tolerance for the embraces for those who are able to, and decrease the sesaling gait, which is because of the imbalance of the abductors and adductors. And it helps with progression, the treatment progression. Surgeries which are indicated, one, for every, that's why we have to plan which surgery to do. Adductor iliopsoas, the indication is migration percentage over 25 to 60%. It improves abduction and sesaling gait. The iliopsoas, we need skill because of the friction deformity. One, the iliopsoas can either be intramuscularly released around the pelvis or at the LT. The lesser trochanter, of course, is indicated in the non-ambulatory because the assessment, of course, tend to review that when you reduce it, when you release it at the LT, it weakens it a lot. And also when you release it at that time, at that point, in the very young ones, they tend to get heterotrophic ossification. But also the pelvic approach, the pelvic brim release is easier for most of us. The proximal femoral osteotomy is to reduce the varus if the child has varus, and also take care of the dilatation, that's the version. But also we also shorten this one to allow us reduce the joint and also avoid a vascular necrosis of the hip, femoral hand because of the pressures. The dagger, of course, is indicated, particularly posterior superior acetabulum dysplasia. The button can use it for the anterior anterolateral hypoplasia of the acetabulum. Lengthening of the abductor for the abductor system, for the windswept or windswept deformities. That's the one side is dislocated and the other one is inside. So you may need to release the abductors to prevent or to correct that deformity. Arthropathy is becoming also, resection hydroplasty is one of the procedures we commonly do for the adolescent who have a lot of pain and pelvic perineal care is poor, and also accompanied by hand deformity as well as dysplasia. The arthroplasty, whether total or resurfacing, the resurfacing, the studies have very few patients and poorly conducted, so we may not recommend it. The arthroplasty, I've only managed to do one. Up to now, the joint is still in place. Surgical plans. Is it the three categories: preventive, reconstructive, and salvage. Preventive, of course, you are trying to have a passive abduction of about 40 to 45 degrees, and also to achieve, for those patients who have migration percentage over 25, and subluxation without osseous deformity. That is, the femoral hand is not deformed, as well as the acetabula is not spherically deformed. You can go for preventive intervention. Mild subluxation in the young age group also can benefit from that category of treatment. In this preventive surgery, is soft tissue releases. We have open myotomies and ductal longus. Now, here in the myotomy is also some physiology as well as biomechanics is important. Remember, the adductor, the glaciales have long tendons. So the muscle fiber tendon ratio is high and the amount of excursion is quite marked. That's why we go for them first. Then the proximal and distal hamstrings release to depend on where you want to attack. Neulectomy of the obturator, the anterior branch of the obturator nerve, of course, we tend to avoid it because of the amount of weakness it may lead to when you denervate the adductors. Of course, it will mean now the abductors are left free and can cause the opposite deformity. The goal of this soft tissue release is at least 30 degrees of passive abduction, 30 to 40 degrees of passive abduction. The cartoon on the side is trying to depict the muscles you are going for. And note the biarticular status and the monoarticular status of the muscles. Muscle lengthening based on the muscle to control the muscles. We have the monoarticular muscles are usually anti-gravity, so take care of them when you are doing the release. That slide, of course, demonstrates what muscles and where you are going to attack them. If the patient has very severe adductors, I usually go for adductor longus and then gracilis. Occasionally, if I feel I've not released, I go for the any tight deep fascia fibers, and then I may turn my attention to the sartorius muscle. Now, remember when you are trying to achieve this stretching or collecting this flexion deformity of the hip, as well as the knee, if you collect 100% of those deformities, you may precipitate neuroplasia of the sciatic nerve. And when you precipitate that one, it will give the child a prolonged painful period, which is difficult to manage. And most of these children are not talking, so they just cry, refuse to eat, and you don't know why. Pelvic reconstructing osteotomies decisions are based, one, on poor head coverage. So you have to have a very good X-ray. And this, of course, after you have done your varus dilatation osteotomy, on fluoroscopy, you assess, as well as the stability of the hip intra-op is very key when you are taking the decision of pelvic osteotomies. The high migration percentage, of course, will help you decide on where to do osteotomy or not. Acetabulary index of 25%, and then type 2 and type 3 social. Note that reconstruction strategies may include all of them: soft tissue release, varus dilatation osteotomy, as well as pelvic osteotomies, femoral shortening, and capsulography. That's what is called as total reconstruction strategy, and more so for the migration percentage of 80% and above. Reconstructive osteotomies, what are these? The reconstruction of the pelvis, of course, are divided into redirection at the Salter and Manis periacetabular, and it's reshaping Degas and Pemberton. The difference between Degas and Pemberton is the patella you are using to identify, as well as the pelvic wall. Then, of course, when you have done this, the varus dilatation and pelvic osteotomy, that of course reduces or makes the migration stagnate within 5 weeks. Means it's a well-working procedure. Remember, after fractures, the changes of the growth plate around the acetabula. That's one of the least. My conviction that this could be working by stagnating the migration. If the reconstruction osteotomies have not worked or the patient comes to you late, then there is a salvage procedure. The carry and self procedure, of course, is to increase the surface area, articulating surface area. That reduces the stress, the contact stress, and hence osteoarthritis. The girdlestone, the problem with the girdlestone, of course, is because of the muscle spasms, the femur tends to piston upward or migrate upward and wraps over the lateral surface of the ilium, and hence the pain. The valgus osteotomy. The valgus osteotomy can either be subtrochanteric or trochanteric lesion, which is geared towards articulating with the acetabula. So acetabula articulating valgus osteotomy is at the trochanteric level. The subtrochanteric also region, you can gear it towards articulating, but also pelvic support osteotomy, which is far much down. The problem with that one is, of course, the shortening of the limb. Now, when you do osteotomy in pediatric age groups, the challenge, of course, they tend to remodel. Remember the remodeling of the fractures in children, and the strengthens up again. So that's the big problem. Arthrodesis for patients who have unilateral, that's hemiplegia, and the other side is normal. you can do arthrodesis to relieve the pain. The problem is also you may precipitate other challenges like of the sitting, but always make sure that the opposite hip is normal, and hence that can only obey in hemiplegia. Hip replacement, the challenges of course is dislocation rate is very high, and you may need to put a hip spiker, for example, to hold for the muscles to heal. But it's not a common practice. I've only performed one in an old man of 38 years who had severe osteoarthritis and subluxation. Up to now, the hip is in place. The only trick of that one is you tend to abduct the cup, the shell, as much as possible to prevent the superior telescoping, pistoning of the femur. Those are some of the pictorial presentation of the osteotomies you may do. The first X-ray is the Chiari. This one I've got it from the internet. Then the varus osteotomies with the plates. You can use the use of the model, the contour and the plates, or you contour your plate. The 3.5 higher profile is the common one I use. Now, I have a few cases which I want to share with you, have managed at Meru. The case number one is a 12-year-old girl who had pain, subluxed, and limited abduction. And one thing we should appreciate in surgery, bone surgery of these children, is they tend to bleed a lot. And also the anesthesia is a challenge, as well as the position. So the surgery you are skilled at, which you can perform very fast and will help. I think that's the best advice. So I did that self osteotomy. If you look at the senton line, it has been reconstructed. Why I use that small, that's a low profile 3.5 plate. It's holding on the flipped, downward flipped external surface of the ilium. And then I did a subtrochanteric osteotomy. You can note that I've used two plates, one because when I use the small low profile and trying to collect it towards bending, so I had to hand a second plate. So that is the self-assembloplasty. The second case is a 16-year-old boy who came to me recently, had an osteotomy, resection hydroplasty. Then after that, varus osteotomy, acetabular articulating osteotomy. It remodeled, and the child tended to have pain, developed pain, and also poor perineum care. So when he came and to remove those plates, remove the proximal part of the hand, and ended up with the X-rays you are seeing on your left side. The implants I removed are there, and also the portion of the bone I removed is there. I interposed the soft tissues to prevent the bone from rubbing, the femur from rubbing onto the ilium. Case number 3 is a young one of about 4 years and a subluxation. This one I just went for short osteotomy, and then varus osteotomy. And I had to fix, because of instability, I had to fix to hold the hand in position with a K-wire and a hip spiker. That child looks like there is internal rotation, but it's the projection of the X-ray. Case number 4, a 10-year-old girl, painful hip, limited abduction and rib length discrepancy. This one, I had gone to do the pelvic osteotomy and other things, but when I opened the capsule, I found the hand was really deformed and osteoarthritic. Now, there are some literature or some papers which allude that if after you have reconstructed this hip, they tend to have pain control. They don't develop pain control. But the big question is the measurement of the pain in these children. So I may not probably confidently advocate for the reconstruction when the hand is deformed and the cartilage is worn out. After reconstruction, of course, being excision, I did a 2 days skin traction just to relieve the pain and the muscle spasms, and thereafter analgesics, and they went home. Post-operative care of these children is challenging, of course. They are not talking, particularly those who are the higher levels of gross motor function, and pain management is of essence. Post-operative epidural, have used it a lot in these children. They are more comfortable. Then diazepam is a must to relieve the muscle spasms. Ketorolac, sometimes I use Brufen, Brustan. The problem Brustan is for children who are aspirating. They tend to get, I've noticed they tend to get wheezing. Then unweight bearing for those who are walking around, I think is important. Monitoring of the failure, of course, after a treatment, you monitor the failure. And the failure is defined as migration of more than 50% after your surgeries. This may call in a repeat surgery, whether it was soft tissue or bone surgery. Now, depending on the class of the patients, you may expect failure rates. And the failure rates as type 2 gross motor function is 6, 3, 50%, 4, 70%, and 5, 80%. So the higher the gross motor function, the poorer the gross motor function classification, the higher the failure rate. So these patients need to be followed up very closely. Now, the challenge I have observed is because of the puberty and the distance they come from, they may not make it twice or even thrice in a year. So you have to probably call them or remind them they are supposed to come to the clinic, or you send them to the nearest physiotherapy or nearest institution for the follow-up. In conclusion, hip surveillance is a must. So we need to develop our hip surveillance protocol in our country, and then early proactive treatment strategies. Maybe stretching, maybe position, maybe soft tissue release, and all bone reconstructing procedures. The clinical and the radiological examination is very key, which is based on the child's age, and then the gross motor function. The non-operative prevention in all children is very key. Migration percentage of over that 3% consider operative intervention because stretching, position, pills in between will not help. Let the salvage surgery be the last resort, and can only be the last resort if we monitor our children carefully and probably intervene. Standardized evaluation is very key, and the follow-up of these children to maturity age group, which is a challenge in our country because as they grow old, they become heavier. Parents are not, it's an inconvenience for them to be brought to the hospital. Thank you very much, folks, for listening to me. Hello.
Hi, Dr. Gakuya.
Hi.
Thank you for the presentation. We have the questions on the chat. I'm not sure whether you're able to see them.
Oh, poor me. No. How do I get these chats now?
Stop sharing your screen.
I stopped sharing my screen. I've stopped. Irene.
And then look at the chat below here.
At below here, there are 3 questions. Thanks, Dr. Sometimes we get cerebral palsy patients with fractured femur, which is difficult to manage, either hip spike or cast or skin traction. Hi, doc. How do you manage? First, for children with cerebral palsy, one, we appreciate their bone osteopenia, and also when you use the implants, they tend to fail. If it's gross motor function class 5, the best is bulk splintage. You put a lot of cotton, and also you splint with a POP. That tends to build them out. For those who are mobile, you can try fixing them, of course, with special implants like the place on nails. But remember, casting, of course, there is casting-mediated osteopenia. The argument is the deterioration of bone density. But you need this patient to heal, the fracture to heal in a good position. So it's a balance. But for the gross motor function class 5, you can just put enough cotton and splint with a POP just for the fracture to heal. Then there is, oops, I'm lost. The chat is gone. Hello?
Hello.
The chat is gone. Something has cropped up in my screen.
You can just try again and tap on the chat.
Okay, I've seen it. What can be done for an adult in our 50s who has deformities but still ambulatory without great difficulty? You have to evaluate that patient very well. And the ambulation, is it walking or on a wheelchair? I think the key thing you want to achieve is the posture, upright posture, or the sitting balance to sit on a wheelchair. So it depends on what you find on physical examination, X-ray, and the expectation of the patient. That may not be a straight answer to give. And I think those are the only two questions I can see. Irene. Hello?
All right, thank you, Dr. Gakuya.
Welcome, please.
Hello, you can hear me?
Yes, can you hear you?
Hello?
Hello?
Oh, thank you, sorry. Yeah, thanks. Hello, you can hear me?
Yes, please.
All right, thank you for the presentation, Dr. Gakuya.